Hepatic encephalopathy definition. Hepatic portal systemic or encephalopathy is a complex neuropsychiatric syndrome characterized by disturbances in consciousness and behavior, personality changes, fluctuating neurologic signs, asterixis or flapping tremors, and distinctive encephalographic changes. Encephalopathy may be acute and reversible or chronic and progressive. In severe cases, irreversible coma and death may occur. Acute episodes may recur with variable frequency. Pathogenesis. The specific cause of hepatic encephalopathy is unknown. The most important factor in pathogenesis are severe hepatocellular dysfunction and or intrahepatic and extrahepatic shunting of portal venous blood into the systemic circulation so that the liver is largely bypassed. As a result of these processes, various toxic substances absorbed from the intestine and are not detoxified by the liver and lead to metabolic abnormalities in the central nervous system. Ammonia is the substance most often discriminated in the pathogenesis of encephalopathy. Ammonia is the substance most often incriminated in pathogenesis of encephalopathy. Many, but not all, patients with hepatic encephalopathy have elevated blood ammonia level. Many, but not all, patients with hepatic encephalopathy have elevated blood ammonia level, and recovery from the encephalopathy is often accompanied by declining blood ammonia level. Other compounds and metabolites that may contribute to the development of encephalopathy includes mercaptans derived from intestinal metabolism of methionine, that is short chain fatty acids, and phenols, short chain fatty acids and phenols. False neurochemical transmitters, example octopamine, resulting in part from alterations in the plasma level of aromatic and branched chain amino acids may also play a role. An increase in the permeability of blood-brain barrier to the some of these substances may be an additional factor involved in the pathogenesis of hepatic encephalopathy. Severe observations suggest that excessive concentration of gamma aminobutyric acids GABA an inhibitory neurotransmitter in the CNS are important in the reduced level of consciousness seen in the hepatic encephalopathy. Increased CNS GABA may reflect failure of the liver to extract precursor amino acids efficiently or to remove GABA produced in the intestine. In support of this, there is also evidence to suggest that endogenous benzodiazepamines endogenous benzodiazepamines which act through the GABA receptors may contribute to the development of hepatic encephalopathy. This evidence includes isolation of 1,4-benzodiazepamines from brain tissue of the patient with a fulminant hepatic failure, as well as the partial response observed in some patients and experimental animals after administration of flumazenil flumazenil, a benzodiazepine antagonist. However, the inconsistent effect of flumazenil in patients with encephalopathy as well as potential methodologic pitfalls in measurement of endogenous benzodiazepines preclude definite attribution of a role of these substances in pathogenesis of hepatic encephalopathy. The finding of direct encephalopathy of GABA receptor, the finding of direct enhancement of GABA receptor activation by ammonia suggests that several of the factors described above may be operating via a final common pathway to produce the neuronal depression of hepatic encephalopathy. Finally, the observation of hyperintensity in basal ganglia by magnetic resonance imaging in cirrhotic patients suggests that excessive manganese deposition may also contribute to the pathogenesis of hepatic encephalopathy. Further studies are needed to determine whether the chelation therapy exerts long-term benefits. In the patient with otherwise stable cirrhosis, hepatic encephalopathy often follows a clearly identifiable precipitating events. Perhaps the most common predisposing factor is the gastrointestinal bleeding, which leads to an increase in the production of ammonia and other nitrogenous substances, which are often absorbed. Similarly, increased dietary protein may precipitate encephalopathy as a result of increased production of nitrogenous substances by colonic bacteria. Electrolytes disturbances, particularly hypokalemia, alkalosis, particularly hypokalemic alkalosis, secondary to overzealous use of diuretics. Vigorous paracentesis or vigorous paracentesis or omitting may precipitate hepatic encephalopathy. Systemic alkalosis causes an increase in the amount of non-ionic ammonia. Systemic alkalosis causes an increase in the amount of non-ionic ammonia, that is NH3, relative to ammonia ions, that is NH4 positive. Only non-ionic uncharged मतलब NH3 ammonia readily crosses the blood-brain barrier and accumulates in the CNS. Hypokalemia also directly stimulates renal ammonia production. Hypokalemia also directly stimulates renal ammonia production. Injudicious use of CNS depressing drugs, that is barbiturates, benzodiazepines, and acute infection may trigger or aggravate hepatic encephalopathy. Although the mechanism involved are not clear, other potential precipitating factors include superimposed acute viral hepatitis, alcoholic hepatitis, enhanced extrahepatic bile duct obstruction, constipation, surgery, and other coincidental medical complications. Hepatic encephalopathy has protein manifestations and any neurologic abnormality, including focal deficits, may be encountered. In patients with acute encephalopathy, neurologic deficits are completely reversible upon correction of underlying precipitating factors and or improvement in liver function. But in patients with chronic encephalopathy, the deficits may be irreversible. In chronic encephalopathy, the deficits may be irreversible and progressive. Cerebral edema is frequently present, and contribution to clinical picture and overall mortality in patients with both acute and chronic encephalopathy. The diagnosis of hepatic encephalopathy should be considered when four major factors are present. That is, the first one acute or chronic hepatocellular may be either spontaneous, example secondary to portal hypertension, or surgical created, example portocaval anastomosis. Number second, disturbances of awareness and mentation, which may progress from forgetfulness and confusion to stupor and finally coma. Third one, shifting combination of neurologic signs including asterixis, rigidity, hyperreflexia, extensor plantar signs, and rarely seizures. And fourth one is a characteristic but non-specific symmetric high voltage triphasic slow wave ECG का है ये 2 to 5 पर 2 to 5 per second pattern to the electroencephalogram encephalogram चाहते asterisk that is in bracket liver flapping tremor is a non-rhythmic asymmetric lapse in voluntary unstressed by having the patient extend the is a non-rhythmic asymmetric asterisk is a non-rhythmic asymmetric lapse in voluntary sustained position of extremities, head and trunk. It is best demonstrated by having the patient extend the arms and dorsiflex the hands, because initiation of asterisk depends on sustained voluntary muscle contraction. It is not present in comatose patient. Asterisk is non-specific and also occur in patient with other forms of metabolic brain disease. Disturbances of sleep with reversal of sleep wake cycle are among the earliest signs of encephalopathy. Alteration in personality, mood disturbances, confusion, deterioration in the self-care and handwriting, and daytime somnolence are additional clinical features of encephalopathy. Fetal hepaticus, a unique misty odor of breath and urine behavior believed to be due to mercaptans, may be noted in patients with varying stages of hepatic encephalopathy. Grading or classifying the stages of hepatic encephalopathy is often helpful in following the course of illness and assessing response to therapy. One useful classification is shown in 29.4 table. The diagnosis of hepatic encephalopathy is usually one of the exclusion. There are no diagnostic liver function test abnormalities. There are no diagnostic liver function test abnormalities. Although an elevated diagnosis of hepatic encephalopathy is usually one of the exclusion. There are no diagnostic liver function test abnormalities, although an elevated serum ammonia level in the appropriate clinical setting is highly suggestive of the diagnosis. Examination of cerebrospinal fluid is unremarkable, and computed tomography of the brain shows no characteristic abnormalities until late in stage 4, when cerebral edema may be supervened. A number of conditions, particularly disordered related to acute and chronic alcoholism, can mimic the clinical features of hepatic encephalopathy. These include acute alcoholic intoxication, sedative overdose, delirium tremens, Wernicke's encephalopathy, and Korsakoff's psychosis. Subdural hematoma, meningitis, and hypoglycemia or other metabolic encephalopathies must also be considered, especially in the patient with alcoholic cirrhosis. In young patients with liver disease and neurologic abnormalities, Wilson's disease should be excluded. Now the treatment. Early recognition and prompt treatment of hepatic encephalopathy are essential. Patients with acute severe hepatic encephalopathy stage 4 require the usual supportive measures for the comatose patient. Specific treatment of hepatic encephalopathy is aimed at number 1 elimination or treatment of precipitating factor, and number 2 lowering of blood ammonia and other toxin levels by decreasing the absorption of protein and nitrogenous products from the intestine. In the setting of acute gastrointestinal bleeding, blood in the bowel should be promptly evacuated with laxatives and enemas of if necessary in order to reduce the nitrogen load. Protein should be excluded from the diet and constipation should be avoided. Ammonia absorption can be decreased by administration of lactulose, a non-absorbable disaccharide that acts an osmotic laxative. Metabolism of lactulose by colonic bacteria may also result in an acid pH that favors conversion of ammonia to the poorly absorbed ammonia ions. In addition, lactulose may actually diminish ammonia production through its direct effect on bacterial metabolism. Acutely lactulose syrup can be administered in the dose of 30 to 60 ml every hour until diarrhea occurs. Thereafter, the dose is adjusted, usually 15 to 30 ml 3 times daily, so that the patient has 2 to 4 soft stools daily. Intestinal ammonia production by bacteria can also be decreased by oral administration of non-absorbable antibiotic such as neomycin 0.5 to 1.0 gram every 6 hours. However, despite poor absorption, neomycin may reach sufficient concentration in the bloodstream to cause renal toxicity. Equal benefits may also be achieved by broad-spectrum antibiotics such as metronidazole. The use of agents such as levodopa, bromocriptine, keto analogues of essential amino acids, and intravenous amino acid formulations rich in branch chain amino acids in the treatment of acute hepatic encephalopathy remains of unproven benefits. Flumazenil, A short-acting benzodiazepine antagonist may have a role of management of hepatic encephalopathy precipitated by use of benzodiazepines. If there is a need for urgent therapy, hemoperfusion to remove toxic substances, and therapy direct primarily toward coincident cerebral edema in acute encephalopathy are also of unproven value. The efficacy of extracorporeal liver assist devices employing hepatocytes of porcine or human origin to bridge patient to recovery or transplantation is an yet unproven but is currently being studied. Chronic encephalopathy may be effectively controlled by administration of lactulose. Management of patients with chronic encephalopathy should include dietary protein restriction, usually to 60 gram per day, in combination with low doses of lactulose or neomycin. Nephrotoxicity or ototoxicity may be limiting in prolonged uses of neomycin. There are suggestions that vegetable protein may be preferable to animal protein. Thank you.